What's going on, guys? So we're going to go ahead. We're going to do an assessment of the shoulder. We've got Hannah here, and she's going to be our demonstration model. So the first thing that we should do is let's go ahead. Let's have Hannah come to a standing position. So Hannah, are you experiencing any shoulder pain in real life?
No.
Okay. Well, let's do this. The first thing I want you to do is I want you to imagine your right shoulder is the one that's giving you your pain and discomfort. I want you to take it. Let's come to the front for me, just as far as you can. Okay, so you're going to lift right to the front. Good. And so what we're noting here is this, is that we're looking at the quality of her motion. So she comes up to the front. Go up and hold it up as high as you can. Okay, good. Okay, so right off the bat, we see that there's perhaps a mild lack of motion here. If I had Hannah turn to the side for us just like this, I'm noting that if we're drawing a line from the midline of the torso in through here, we're lacking a little bit coming down just like this. Now, if Hannah were to extend straight back for us, good. How do we do there? Excellent. Noting hiking of the shoulder, which is occurring. Don't take any of this personally, okay? Good. And then Hannah turns for us. Good. Now, what I want you to do is I want you to take it, and I want you to raise out to the side. Good. Now, what we would be looking for here in these positions would be the scapular mobility. So what we may see here is hiking of the shoulder. So if she hikes the shoulder, that would be something qualitative to note. If I had Hannah turn around, thanks for letting me just move you around. Palm is up for her. She goes out to the side again, looking at scapular rhythm here, okay? So knowing that essentially 1/3 of the motion occurs here, 2/3 occur here. It's important that she get good rotation of the upward rotation of the scapula. So go ahead and do that for me one more time. We don't have fantastic. She's wearing black here, and that's perfect. If I were, it may be advisable to have the patient wear a gown or something like this so you can really get a visual on the scapula. But I just want to show you through what's going on here. So we've got active motion assessment. Let's have you now take it. What I want you to do is I want you to come into this position for me, Hannah. I want you to externally rotate. Good. Looking at the quality of the motion here, okay? So that's as far back as you can go there? Good, yeah. So she can get a lot more there. Any pain or discomfort with that?
Very.
Where is it that you're feeling it? Very mildly. Okay, in through there. If you were to take it and if you were to do the opposite and go down for me, good. Look, she's got a ton of motion here in the shoulder, okay? Any pain or discomfort in those positions?
Here.
Right in through there?
Very
Okay.
small.
Yep, very good. Now what we've done is we've done sort of flexion, abduction, external rotation, internal rotation. We could do the same thing here at neutral. So if she went out just as far as she can, we would anticipate less motion here than we would at 90 degrees unless she's got a capsular restriction of the shoulder, which would be something like an adhesive capsulitis. Okay, very good. Now we should always perform overpressure. So if she went up just like this, if she said no pain or discomfort, I would just cup the scapula here, so prevent motion, provide a little overpressure there. Any pain or discomfort with that?
No.
Good, and then she comes down and reaches back just as far as she can. Any pain or discomfort with that?
Just
A little bit. If I perform a little overpressure here, does that worsen it or no change to that?
Lesson.
Lessens it. Okay, interesting. And then she goes out to the side just like this. Go ahead and go out to the side. Yep, you're going to go thumb up for me just as high as you can. Good. Any pain or discomfort with that?
No.
Okay, just like this. Great. And now let's go ahead and relax, okay? So let's take your arm just like this. Take it. Pain or discomfort?
Still kind of right there.
Still a little bit in through there. And then we come down here just like this. Any pain or discomfort?
Not really.
And relax. Okay, so whenever we're looking at the shoulder, it's important to make sure that we're screening the neck and the thoracic spine. So if she looked up for me, does that cause any shoulder pain or discomfort? Look down for me. Any pain, shoulder pain or discomfort?
No.
Good. Rotate. Come up nice and tall. Good. Now look towards me. Good. Any pain or discomfort? And then look away from me. Any pain or discomfort?
No.
Okay. Then we provide overpressure, so she looks down again. Good. Right, that overpressure there. Pain or discomfort?
A little bit like middle back.
Okay. Anything in the shoulder with that?
Not shoulder.
Excellent. Okay, she looks up to the ceiling. Okay, I'm going to provide a little overpressure touching the forehead. Any pain or discomfort here with that in the shoulder? Good. Okay, she rotates towards me. Any pain or discomfort? I'm going to touch your face. Any pain or discomfort in the shoulder? Want to give you a little turn? No. So it feels like she's got a little stiff neck, just a little bit. Good. She rotates. Rotates towards me. Good. Touching the face. Any pain or discomfort in the shoulder when I perform that overpressure? Good. And we can always do our quadrants there. I just really want to demonstrate we're here. And we're here, okay? If she reported that something were painful, so say, for example, she said, yep, this hurts, okay? Then what we should do is we could look up and see if that changes it. We can look down and see if that changes it. We could have her go chest down and see how that feels versus chest up. If one feels different than the other, then that's an example of differentiation of selective tissue tension testing. So if she reports that this is here and we can alter it by head up, head down, head left, head right, then that would indicate that the neck is a likely source. If we can adjust it with chest down, chest up, something like that, then we can get thoracic spine involvement here. So those are important. Next, what we got to do is we got to look at the scapula. So again, we said in order to get that arm out to the side where the scapula needs to move. Imagine a scenario, Hannah, in which you said, ow, that's painful right there, okay? Then what we would do is this. Looking at Hannah from behind, let's imagine. Good, we're right here. Good. Okay, I'm going to trace Hannah's scapulas. Now, Hannah, what I want you to do is I want you to take both hands. I want you to make the snow angel with both hands. Go ahead. And we feel on the scapulas and see how these scapulas are moving. Go ahead, do that one more time. That's it. Good. And down. Do it one more time for me, Hannah, in real life. Go ahead. Okay. I'm noting that the left side moves a little bit better than the right side, if I'm being honest, okay? History of right shoulder issues or pains or anything like that in the past?
If anything, left shoulder.
If anything, left shoulder. Her left shoulder actually looks like it's moving pretty good. Now, if we were to perform a scapular assist here, one of the things that we can do is this, okay? So what I'm going to do is this. I'm going to take my hand here, and I'm going to try to assist the scapula in moving, okay? So I'm going to put my hand on the front of your arm just like this. Okay, I'm going to scoop under the scapula. What I'd like you to do is this. You're going to lift, see how it feels, and then I'm going to give you an assistance. Okay, so go ahead and lift out to the side for me. Good. Think about how that feels. All right. Now what I'm going to do is I'm going to put you in that position again. Here we go. 3, 2, 1. And she slides. And what I'm trying to do here and come back down is I'm trying to assist that scapula to move. There she is. I know, and I'm kind of pushing you off to the side. But the question I would ask is there a difference in the quality or in how it feels?
Easier.
It feels easier. If it feels easier as I mobilize the scapula, what that would indicate is how what she needs in order to feel her best is to get that scapula moving. So that's a quick differentiation test of the scapula, which is excellent, okay? Now, we've already sort of mentioned some overpressures. So I've had Hannah do overpressure here. So we've got flexion, overpressure. We've got extension, overpressure. Kind of running through these again. Abduction, overpressure. Good. We've got external rotation, overpressure. Internal rotation, overpressure. And now what we should do is we should work on our quadrants. Okay, so our cardinal. We just did cardinal plane. So if she goes diagonal across. I know. Sorry about going across a bit. Any pain or discomfort with that? Good. Okay. This would be good for clearing the shoulder. Good. Any pain or discomfort with that?
I guess like a little bit. Bicep
Mild and through there. Okay, interesting. If we were to take it and if we were to come back like this, pain or discomfort there. Elbow. Okay, and if we were to come down just like this and provide a little overpressure there. Okay, any pain or discomfort there in the shoulder with that? Excellent. Okay, so now what I want you to do, Hannah, is let's go ahead and have you lay on your back for me.
All right.
Good. She's doing so good. She's such a good assistant. Okay, great. Now what we're gonna do is we're gonna look at sort of mobilizing the scapula. Okay, what I really mean is this. We're gonna look at sort of assessing the AC joint, okay, the SC joint, and how those arthrokinematics play a role. So starting with the SC joint, let's palpate. Okay, I'm here by myself, so we're a one-man band here. There she is. Good. Okay, but let's palpate. Can I palpate sort of in your along your midline? Okay, great. So let's go ahead. We're getting on the manubrium, tracing off. Okay, then we get right on the SC joint, which is going to be right there. There's her SC joint. Palpate that. Now, what kinds of motions occur at the SC joint? Well, this is what we learned in the lab, is you can perform an anterior to posterior force. Sorry about my camera not being absolutely ideal here, but, we do our best. Good. You do what you gotta do. I know. It's like I want to set it up in such a way where like, if you could hold that while you're getting your own, that's it. Great. Okay, good. I know, she's so good. Okay, so we can find that joint line. Good. Dummy thumb right here. Good. Seeing if that reproduces any symptoms. So we're doing an A to P. We can do an inferior glide of the SC joint, which would be just like this. Good. You could let's talk about doing a roll. We could do a superior glide, just like that. Any tenderness with those? A little bit, okay. Yeah. And we want to know if that reproduces the patient's symptoms. Okay, if we trace the collarbone, the clavicle out to the side, then we get to the AC joint right here. We can do the same thing with the AC joint. Take it. We're going to perform an inferior glide just like that. Any tenderness with that, Hannah? Okay, we got an A to P just like this. Any tenderness with that?
A little.
Okay. We got what was called a waggle. We can waggle it just like this, and I'm kind of taking it. I'm just going up and down, just assessing gross mobility here. Any tenderness with that one right through there?
A little, yeah.
Little tender, yeah, correct. Good. And what we should know is that we're always thinking to ourselves, not just whether or not that's tender, but whether or not that reproduces the patient's symptoms. What's important to know here is that when she goes into flexion, we're getting both elevation and a posterior roll of the clavicle in the SC joint. When she goes into flexion and abduction, there's a relative inferior glide of the AC joint in relation to the clavicle. So the acromion slides inferiorly in relation to the clavicle. It gets pretty sort of in the weeds with these kinds of things, but know that essentially the clavicle needs to both, for her in relation to what we're talking about here, her clavicle needs to upwardly rotate and rotate posteriorly when she goes overhead. And if those are lacking, then she's definitely going to feel pinchy in through that anterior shoulder. The final thing that we should be doing is doing a quadrant assessment of the patient's shoulder. And so this was demonstrated in the Maitland, and I found a really good video that sort of went through this. So let me go ahead and put ourselves in these positions. What we're going to do is this. We're going to take her, and I'm facing her head. I'm just going to take control of her arm. What I'm going to do is I'm going to take it, and I'm going to put you, you just relax your arm just like this. Okay? There they are. Hey, you guys. I know, we're having fun. Okay? And I'm going to depress her shoulder. The purpose of me depressing her shoulder is that we want to not incorporate the movements of the scapula in this. So we're really sort of assessing what we got here. What you're going to do is you're going to take it, you're going to take the arm here, and you're going to control the elbow. We're here just like this. You okay in this position? Okay, you take it. You're going to perform a little abduction just like this. Okay, you take it. And we're going to move into these positions. Seeing if we replicate any sort of patient symptoms. Imagining the scour of the shoulder and quadrant testing of the shoulder is a lot like quadrant testing of the hip. We're checking for capsular tightness here. So whether or not that reproduces any of the patient's symptoms, we can even pin the scapula down and perform some of these. I'm almost performing a scour of the shoulder to see if there's anything going on intra-articular wise with the shoulder. And that would be that right there. Let me just check and make sure that I haven't forgotten something. Just one moment. And I think that might be just about it. And if I were to really be an all-star. I didn't have her do this, but in retrospect, if you wanted to nitpick this video, the nitpicking of the video would be that the patient needs to be exposed, okay? Honestly, you got to see the scapula. And so if I were to do it again, I didn't have her do it, okay? Because I kind of grabbed her at the last moment, right? But in theory, if the patient were coming in here with shoulder pain, you would certainly want to expose the shoulder so that you can properly see all the mechanics that's going on. And again, differentiation tests, if it were coming from the neck or the thoracic spine, then adjustments to those things would have an impact on the patient's pain while you're doing those. So just checking to make sure I got everything, and I think that's it. Okay, well, thanks, guys. I appreciate you, and have a good one.